I'd like to introduce right now Josh Sharfstein, who's the State of Maryland's Secretary of Health and Mental Hygiene, who's kindly agreed to be the moderator for our panel discussion session. Josh? Sorry. Yeah, and I'll invite the other panel discussions to come up and grab their seats right now. Great.
Thank you very much. While we're waiting for everybody to take their seats, I'll just say that I'm a little disappointed because I'd been hoping that Dr. Osterholm would have told us what he really thinks. But I do hope we'll have the chance to draw him out a little in the question and answer period. Okay, why don't we go down the line. My name is Josh Sharfstein. I'm the Secretary of Maryland's Department of Health and Mental Hygiene, and I am looking forward to this discussion. The main point of this period is to get questions and answers. But in order to prepare people for that, I think it would be helpful for each of the panelists to just give a brief introduction to what they do and their interest in Ebola.
So good morning. My name is Rich Rothman. I'm an emergency physician here at Johns Hopkins. I'm also a professor and vice chair for research in the Department of Emergency Medicine. I've done work over the past 20 years that I've been here at Hopkins on program development in emergency settings for rapid diagnosis of various infectious diseases, specifically HIV and influenza. I've been involved in the Regional Centers for Excellence for Emerging Infectious Diseases, where we've looked at developing diagnostics for various infectious agents, and now I'm co-director with Andy Picos on the an Influenza Center for Excellence here at Hopkins.
My name is Nancy Cass. I'm a professor here at the School of Public Health and also in our university's Berman Institute of Bioethics. And I've become a little bit involved in thinking about the ethics issues in Ebola. We have a long history of thinking about ethics issues in public health, including in infectious outbreaks, and we've been starting to do a little work particularly focused on Liberia.
Hi, I'm Bill Glass. I'm the Director of Strategic Communication Programs at our Center for Communication Programs here at the school. I oversee the teams that manage our field work now in about 30 countries. And my main message as part of this panel today is going to be that communication and social mobilization are at the heart of our response today. It's important throughout the care continuum. Communication can help us prevent, it can help us care safely, treat safely, and have safe burials, and as was mentioned before, increase vigilance and decrease complacency. And to do that, we have to have better coordination and consistency of our messaging, and if we do that, we can build trust, we can reduce fear, we can address rumors, we can raise confidence in clinics, we can inspire communities to take action and provide households ways to stay safe. So that's my main message, and just very briefly what we've been doing as a center. So we've been involved in the response in Liberia since the very first cases through our staff that have been there under USAID funding. But recently we've been asked to ramp up our response in Liberia and regionally. In Liberia, we're doing all kinds of communication activities, including helping with the hotline that's overwhelmed there these days, and working on monitoring and evaluation systems where we've put things into the field recently. And then soon we'll be involved in mass media and community care. And then the second part of our response is in regional preparedness, where we're seconding staff to UNICEF in New York and Guinea-Conakry and working with them locally and developing preparedness tools and helping countries create their preparedness strategies in terms of communication. And just finally, I want to say that it's been a fabulous effort on behalf of CCP staff around the world to mobilize for this, and kudos to the staff that have been there for quite some time and are traveling there as we speak. So thanks. I look forward to the conversation.
Thank you.
Good morning. My name is Derek Cummings. I'm an associate professor in the Department of Epidemiology here at the school, and I've worked in multiple emerging pathogens to characterize transmission dynamics of MERS-CoV, influenza, and others. In Ebola, I've worked to characterize transmission using national scale data, and I'm currently working with Dr. Peters and others to design surveillance systems to characterize transmission, clinical outcomes for the units that you heard about being deployed to Liberia from DRC. So a couple points that I'd like to make is I think the burden due to other pathogens beyond Ebola is something that we certainly need to be concerned about both now and into the future, but I also think that there's an opportunity to integrate them into the response to Ebola. There's lots of causes of fever, lots of causes of symptoms that will be potentially in cases of Ebola where people might present to clinics, and right now this might be the only sort of capacity to treat them. And so there might be an opportunity to both impact the burden associated with malaria, the number one cause of mortality and morbidity in all three of these countries, and also reduce a burden of febrile cases that might show up later because of potentially distributing anti-malarials in broad response. I think taking up something that Dr. Alsterholm said, I think in the international research agenda, some of the details of this response and where it's failing and where it's succeeding is a target of research. We have tools that have contained Ebola epidemics in the past. I think we have a problem of scale that Ebola really makes it, as it spreads, it makes it harder and harder to contain it because you're taking up all of the capacity, you're reducing that capacity to respond in ways that control these small epidemics in DRC and other locations. But I think working out the details of where we're failing in this response and just sort of seeing a simple accounting, we just don't have the hospital beds to perform the isolation that we need to respond, and that just, that's killing our response. Sort of working out those details, I think, is something that needs to be done.
Great, thank you.
My name is Michael Osterholm, and I gotta. I often get that wrong. My name is Gabe Kellen. I chair the Department of Emergency Medicine in the School of Medicine, and I have an appointment at the Bloomberg School as well. Rich Rothman and I are both practicing emergency physicians, so there's a certain reality where the rubber hits the road for us related to Ebola. Although I'm here today probably in my role as the director of the Johns Hopkins Office of Critical Event Preparedness and Response, an organization that was given birth in 2003 to manage the overall response of the institution, including the health system and the university.
My name is Lenny Bernstein. I'm a reporter with the Washington Post, and I have no expertise in this matter whatsoever. I spend a lot of my time calling the folks on this panel and sitting in the front couple of rows and asking them to explain this. But I did go to Monrovia for 2 weeks in September and saw virtually all of what Dr. Osterholm spoke about. My assessment is that it's probably even worse than he described, and I'd be happy to get into that when you all want to ask questions.
Great. Well, this is a tremendously talented panel. This has been an unbelievably interesting morning so far. I think that we're going to be taking questions in a minute, but I had a couple, and I first wanted to ask Mr. Bernstein to maybe give a little bit more detail about his experience since he's been recently in the area that has been affected.
Sure. And cut me off whenever you want to. I got there on September 12th, and on September 13th, very early in the morning, we started by going to the treatment centers. I went to 2 of the 3 treatment centers and then a place called Redemption Hospital, which was a hospital that had been turned into a transfer point. At any point in the next 2 weeks that I wanted to, I could go to any of those places. I would always find the same thing. The treatment centers were full. There were people sitting, standing, lying on the ground outside the gates of all of those facilities trying to get in. They generally do not get in. If their symptoms are particularly dire, like if they're being taken out of a taxi cab on a stretcher, they might jump the line. That is a chronic condition there, the shortage of ETU beds. When I left, They opened another treatment center on the Sunday before I left. It's called Island Clinic because it was on Bushrod Island. It opened on a Sunday with 150 beds. On Wednesday, the day before I flew out, it had 173 patients in it. That's just the way it is. They had begun a program in Liberia before I left to simply isolate the sick. They had said, okay, well, we're never going to be able to treat everyone with fluids, electrolytes, and the other things they need, so maybe we can bend the reproductive curve by simply taking the sick and putting them in schools away from other people, so at least they're not infecting two people. Each infected person is not infected two people. Maybe we could get it down to 1.5 or something like that. Most of Liberia is not working. I could never get a really good number on this, but many people will tell you that 80 or 90% of the people are unemployed. Schools are closed. There's a lot of people in the streets. They are just kind of milling about aimlessly. They don't have a sense of purpose. Before Ebola, the monthly income in Liberia was about $400 a month, median income. I have no idea what it is now, but I'm sure it's much lower. People are beginning to have trouble feeding their families. In the slums, in the two big slums in Monrovia, just to show you the kind of thing that public health folks are up against, most people, pardon me, most people have no water, electricity, sanitation, cars, or refrigeration. For the city of Monrovia, which has 1.5 million residents, there are probably 12 ambulances. You can call for an ambulance if you get Ebola or something else for days and days and days, and it won't, the ambulances will not come. Your chances of finding an ambulance there are next to zero. If I had to break down the population into two very broad categories, it would be the people who understand that Ebola is real and are trying to take precautions but are basically ill-equipped to do so, and the people who don't yet believe that Ebola is real and are either denying it because of the stigma associated with it or denying it because denial is a coping strategy. For those who do understand it, I saw people bringing sick and dying relatives to treatment centers. They would take those little plastic bags that you get at the grocery store, and they would wrap their hands, and sometimes they would try to put them on other parts of their bodies because they knew when they brought this person to the treatment center in the taxi cab, they were going to have to take that person out with their own hands and bring them to the gate, and they would try to cover themselves in whatever way they could. I would call that the minority of the people. Most people just pull up in a taxi cab, try to get some help for their relative. If they have the money and they can't get in, they drive off to the next treatment center, or they drive off to the next treatment center. A lot of people don't have the money for more than one trip, and they would just leave the person there or sit there with them. I saw a lot of people very sick and dying outside treatment centers.
I think that is a tremendous explanation, and just really crystallizes the incredible tragedy that's going on. I wanted to ask Dr. Rothman and Dr. Kellen, having heard that, to respond. You're both emergency department physicians. What do you see as the key priorities for the healthcare infrastructure? And to Dr. Osterholm's very serious point, are we on a trajectory to begin to meet those, or what else should we do?
Well, I very much liked Dr. Osterholm's message of not trying to say more than you actually know. The main priorities, as you're hearing in the news, is to try and prevent even the remotest likelihood of transmission in the healthcare setting. And it's scary to the point that we think that there's a mechanism of transmission, and if you take care of that, then you're fine. But I don't recall an infectious disease, respiratory or otherwise, or droplet, where the tiniest amount possibly on your PPE equipment as you're doffing it or taking it off, that it might like brush against some other part of your skin, and then you touch your nose, your eyes, and you're done, or you have a tiny scratch. We don't actually know, but to train everybody that might come into contact in a healthcare setting, we have 4,000, 5,000, 6,000 people any given day who might come into contact with patients. That's a pretty big deal. On the front line, that's an even bigger deal because you have residents, you might have students, you have nurses, you might have nurses who are coming in from an agency because somebody called in sick or whatnot. And so to get everybody trained properly is a problem. Based on and reacting, as you had suggested, things change. And reacting to some extent based on Dallas, but we did have a plan B, and maybe not so much a plan C. We're forming teams to take care of potential Ebola patients so that we have a highly trained, highly drilled staff who takes care of people rather than try and figure out a way to train 4,000 or 5,000 people who might come in contact with patients.
Great. Dr. Rothman, anything you want to add?
Yeah, so I would echo those points. I mean, I think the improving and ramping up the infrastructure for training, across the country and hospitals, and if you're speaking to the U.S. situation, building that infrastructure. I think Dr. Osterholm's point about effective screening approaches is important to make note of, and to gather that information and create infrastructure for understanding transmission and most effective methods for screening. One of the things that we've worked on over the years is at various NIH programs is developing diagnostic tests. I think that wasn't specifically mentioned, but better bedside or tests that could be used to more quickly isolate patients at risk and more quickly make decisions about the need for isolation and treatment.
Great. I'm going to ask a couple more quick questions, and then we'll go to the questions if that's okay. One of the things that I think came out pretty clearly this morning is that the vulnerability of the very weak acute care system in these countries has really, Ebola really has preyed on that. Typically, you think of public health as, prevention, education, field vaccination, but the absence of a real hospital infrastructure has really made it very difficult to contain Ebola. And the question that I have probably for Dr. Cummings and Dr. Osterholm is, to what extent are the interventions that are going to happen in West Africa, how important is it that they build on the internal capacity so that they leave behind a meaningful tertiary care capacity or ability to take care of patients, or is this sort of a discrete problem that can be solved through, a very focused effort on Ebola? Maybe Dr. Cummings, you want to start?
So I think they're two very laudable goals. I think if you had capacity that you could put in place, even temporarily, there would be utility to it. Obviously, less utility than capacity that would build upon the long-term resources of the country. But we're just behind the curve, and I want to address the projections. There have been questions about these projections and sort of models. We don't really need a very complex model to produce pretty good forecasts of what's going to happen at short time scales. If this has been doubling the number of cases over roughly 28 to 50 days, depending upon the setting, then it would be very odd for us to see in the next 28 days, something dramatic would have to happen that we don't see cases double in 28 to 50 days, right? So the 15,000 cases estimate, I think, is extremely optimistic, probably not doable, because we already have 8,000, and in a month, are we going to be doing things all that differently? So I think the projections are relevant to your question, because now every 28 to 50 days, we've doubled what we have to do to respond to this.
The model that you're working on, that to import or to translate over from Congo, how does that relate to this? Is that something that you hope would have an endogenous capacity in the end?
So it's very much sort of right now focused on the short term to provide some resources to get ahead of this. I think it does help long-term capacity, because the outbreak is, with every month, with every 6 months it goes on, it's going to reduce all sorts of factors which will impact the long-term capacity in each of these affected countries.
Dr. Osterholm?
Yeah.
Well, first of all, let me just build on what Derek just said. I think that's a very important point. One of the observations that's very striking is we're getting more and more intelligence from the ground that this is not like a fire line where it's just burning. This is little explosions. And we're seeing clusters of activity that tend to flame and cause a big problem, and then they kind of die down and they come back again. And one of the big questions is, wouldn't it be nice if we had viruses from all of those to see what was happening? How similar or dissimilar are they? What's really going on? How much of it is behavior related, et cetera? The other part you asked about the infrastructure, you know, I know you have some really good neurosurgeons at this place, but if you gave them a sledgehammer and a chisel and said that's all you got to work with, they'd have some problems too. And what we've done with public health is we've basically given them the equivalent of that, of trying to deal with Ebola on top of trying to deal with everything else that's going on. Lenny very articulately really laid out what's going on over there, and trying to overlay comprehensive medical care on top of that is just so difficult. And that's why, you know, Doctors Without Borders has come under some criticism from at least one group that they're not doing more in Liberia in terms of IV therapy, et cetera. And I mean, I have to say, I think they're right on the mark, because they're doing the best they can with what they have under those conditions. And to me, it's miraculous they're doing what they're doing. So I think that that's the underlying issue. We don't really have a good assessment of just how bad things are. And I think the thing that worries me is if you look carefully across equatorial Africa, not just there, but I mean anywhere in the developing world, those same conditions are everywhere. I mean, they may not be as bad as they are in Liberia or Sierra Leone or Guinea, but if this got into Mumbai, you know, if some worker took it there, if this got into Kinshasa, this got into, you know, into Kibera in Nairobi, the slum there, I don't know what would be any different. And that, I think, is the message we all have to start to understand.
So my last question, I want to talk to the idea of therapeutics. You mentioned, Dr. Osterholm, that you thought a vaccine was going to be a critical part of this. We heard about diagnostic tests. In order to test and scale a vaccine, there are a whole range of different questions that come up, two of which are what are the ethical issues in terms of getting it out there and getting it to a wide group of people so you could get the data that you need to base good policy decisions, as well as how do you communicate about doing research in the middle of a crisis like this? So I think I would like to ask for brief comments from Professor Cass and Professor Glass.
Yeah, thanks, Josh. In echoing so much of what you said from what CCP is trying to do with the messaging, and I think we've all seen in the public health response, at least some media reports that almost come across as sort of what's wrong with these people, that they're running away and doing these horrible things to healthcare workers, when clearly people are responding from a place of fear and maybe messages not having been locally crafted, et cetera, in a way that might make a big difference in the public health response. We have that sort of on steroids as a challenge with regard to research. So there certainly are the research ethics challenges about when we're going to start rolling out vaccines. Who gets them first? Do we test them with placebos? Do we do adaptive designs? I think this is a place where really sophisticated methodology and public health compassion and ethics can all be aligned, but it takes sophisticated thinking. In brief, a conversation I had with a methodologist yesterday specifically about this question really made me convinced that adaptive designs are going to be the way to go, so that we feel confident that we're learning whether vaccines and treatments work while being able to maximize the people who get access to something that seems to be effective. We know from the history of research ethics, including in Africa, where we and lots of other people have worked for the last 15 years on research ethics challenges, that there is so much suspicion about medical research, particularly when it comes from the West. We saw what happened with polio, we saw what happened with tenofovir, we saw what happened with meningitis, and you go in with the best of intentions, thinking that you're going to help, and whether the research is sort of just taking blood for all of these virology studies, which would make a tremendous difference. And again, we all know what happens when you take blood, and then people die, and then the rumors start. Or the messages have to do with trying to help people understand what a placebo is and why you're even giving something. You're coming from the United States and giving people nothing simply to learn. I think there's more and more people in Africa trained in ethics who can help here, but a lot of big challenges.
Great. Professor Glass, anything you want to add?
Well, I just wanted to take the opportunity to talk a little bit about the kind of research that we're doing in Liberia. As I said, being part of Hopkins, people look to us in terms of behavior change communication as the experts in research and being able to attribute the effects of programs to the interventions that we're designing. And so what the kind of things that we're trying are a media monitoring system to look at the electronic media to see how messages are trending. We're involved in a knowledge, attitude, and practice survey that's being mounted in collaboration with the government and multilateral agencies. And we're also trying an innovative, very quick system that we're developing to look at a few indicators over phones to get some information from key informants very quickly. Back to the comment that was made before about the virus time. We're having to adapt our methodologies in order to get very quick information. And all of this is trying to uncover the key factors in terms of norms and behaviors that are affecting people's risk behaviors and confidence to act.
Dr. Osterholm, having heard that, what's your level of confidence that would we have a vaccine that we would be able to develop an approach that could engage the population and ethically test it?
Well, first of all, I want to be really clear. I don't think it's going to be an easy issue. I think that if you're in the middle of a crisis, people will tend to overcome other issues of fear and so forth if they think that's what they have. But I think that we also have seen there, and again, one of the issues that I'm having to learn very quickly, and I think we all need to learn, is social culturally, and again, I invite people in the audience who know much more about this than I do. You know, we're talking about these three countries as one homologous kind of place. It's not. You know, you have very different populations with very different, I mean, why were those individuals killed? And if you understand the background to that, it was actually quite hard to understand how they could, these weren't foreign nationals that were attacked, these were natives, and it had to get into a number of different issues. And so I think that it will be complicated, and I think this is where now when I talk about rolling out the vaccine, I'm actually talking about inviting and almost mandating that any program have that research and input component to it now and start understanding that. I mean, if we have a big outbreak in Nigeria with this, you're right. We heard earlier about the polio vaccine issue in northern Nigeria. Why would we expect that we're not going to have some kind of issue there? So I don't think that it's going to be just build it and they will come. But on the other hand, I think we have an opportunity here to maybe put our best foot forward ever if we start thinking about it now and don't handle it like a bunch of public health epidemiologists only, but we handle it as a social cultural event that really needs all of us on board. But you got to have the vaccine to do that. You can't even get there, and I want to make sure I get the vaccine first, and we'll get that in.
Great point. Okay, I think we'll go to some questions, and we will start either way. Let's see who. Go ahead, sir.
Thank you very much. This is a very informative workshop seminar. I'm Isaac Smith. I'm from Liberia. I happen to be the president of the Liberian Association in Maryland, and much of what you said are very, very true. I think we are being fed with information that we can use with our community and with our people back home. My question has to do with one of the presentations. One of the presenters listed a series of vaccines that have been developed or are being developed. Some have been tested primarily on animals and have proved to be not worth the use on humankind. Recently, there was a report of a doctor in Liberia, Western Liberia, Dr. Gobi Lokin, who was mending one of the treatment centers. He had 15 Ebola patients in his care, and just studying Ebola and trying to understand it for himself without medication and the right tools to work with, he discovered that Ebola acts in destroying the internal organs the same way that HIV does. And so he decided to use what he had, which were the HIV medication on his 15 patients. Of the 15 patients, 13 of them survived. there were 2 who died, and the 2 who died were patients that were taken 5 or 6 days after they had contracted the disease. Those who were taken earlier than 5 days, the 13 of them survived. My question is, have you given that the thought, or is there a possibility that we already have a vaccine that could possibly help fight the Ebola crisis? And would you be willing to consider testing the HIV vaccine as a possible vaccine against Ebola at this time?
Sure. Thank you for asking that. I think we heard from Dr. Jarling, and maybe you want that maybe best addressed to you, that some of the HIV drugs have been tested without activity against Ebola, if I heard that correctly. But I don't know if there's anything further that you want to say, or anyone on the panel would want to comment on that. Did I get that right? Yeah, sure, please.
Let me just say we were aware of those reports, and although we suspected the drugs would not work, it's the reason we did the in vitro testing. I showed the data, AZT and 3TC. I forget what that has a trade name. But nevertheless, those 2 drugs had 0 efficacy, and in one case actually had pro-virus activity. We got more virus replication in its presence than its absence. That's not to say that other drugs in widespread use shouldn't be tested, and that's really part of our repurposing program. But, you know, from our standpoint, we were unable to confirm that those drugs might have worked.
Thank you. The question does remind me that one of the critical functions of state public health is not only to work with our healthcare institutions and think about the people who are in Maryland, but also the community that is connected to West Africa. And in fact, the governor asked us to reach out, and we are reaching out to leaders of the African community here in Maryland. And we're going to be talking about ways to support them, both in terms of giving them information that can be helpful and anything else that they need that we can provide. If there are any comments by the speakers, either on the question or on thoughts about what either the school or the health department could be doing for people who are here and are connected to people in Africa, I'd be very interested. Yes, Dr. Osterholm.
Well, I can tell you one of the challenges that we're seeing right now, and I come from the Twin Cities, where, as you heard earlier, we have the largest Liberian population outside of the country of Liberia residing. And it's a community that has been incredibly concerned and organized to try to address this issue. And they've gone through a great deal of pain, many of them living in Minnesota, but knowing what's going on back home. And the big issue that we've run into, frankly, and it's come up now both with individuals but also in the private sector job situation, someone wanting to go back home to help because their mother and their father are now dead. They have 2 younger sibs, and they would want to do something to help, and they want to go back into that issue and then come back to the United States. And it's been a very heart-wrenching experience to say, wait a minute, are you going to even get more risk by going? What's going to happen to you? What can you do with your sibs, et cetera? And we don't have answers for that. I mean, we don't. And this is one of the concerns that's come up. We've seen businesses now that are actually looking at furloughing people for at least 21 days after they've returned from West Africa. And if you do that without pay, I guarantee you'll not find out they're going to West Africa, or at least likely they're not going. You're not going to find out. If you pay them, is that a new situation you want to start? How are you going to follow this? And so we're really, the policies are always a day late and a dollar short. We ought to be looking at these kinds of things now and anticipate that's going to happen more. If this spreads in other countries, it's going to go into other countries, we're going to have the same thing. So this is a huge challenge right now with people from the United States or other countries wanting to go back and help and knowing that they're running into the fire, not away from it.
Yeah, I think that's absolutely true. I think also there's probably some significant level of mental health support that they'll probably also need because it's so traumatic. Yes, Mr. Bernstein.
They need healthcare workers even more than they need treatment beds. It's hard to believe because we are so short on the treatment beds, but it's actually only the second worst problem that they face over there. The major problem is going to be once they're built, and they will be inadequate once they're built, the number will be inadequate. They don't have the people to staff them. So any physician, nurse, or other kind of healthcare worker who feels like they can go over there and is willing to go over there and do something, I think should try to find a way to do so, because that's going to be the number one issue. The one thing you did see that provides a glimmer of hope is that when the resources and the training and the leadership were there, Liberians are taking those jobs. A lot of that is a matter of the economy. They don't have jobs, they're not working, and they are taking high-risk jobs because they need money. But also, they are stepping up and taking very dangerous jobs to try to combat this crisis. So what they need are the folks with expertise who can come over and run the facilities and train people, and I'd say that's probably their most serious need.
And I would, that's very helpful. I would also emphasize it in West Africa as well as here, the critical need to support the frontline health workers is obviously critical, yes.
Yeah, and I just want to add one thing, because I want to echo what Lenny just said, but just think about this. Yesterday, the Liberian national healthcare workers all went on strike. And they went on strike because up to 80% of them do not have masks, gloves, and goggles. And they're being asked to work in these settings. What the hell is wrong with that? Why is that happening? You know, why can't we deliver? We can deliver iPhones from Asia in 24 hours. Why can't we deliver masks, goggles, and gloves to Africa in 1 week? I don't get it. That's the part that frustrates me, because, you know, losing that group of Liberians right now is huge. They are the backbone of what's been done, as you saw over there, and yet I would strike too. And I know how hard that must be for them to strike, because they want to be there to care, but they don't have those. That's the part that is the disconnect I keep coming back to about virus time, program time, bureaucracy time. We got to get those two together, and they are not.
Dr. Cullen?
I just wanted to comment on that because, and Mike, you might know this actually better, but it's not really getting the equipment there. Even before the U.S. and the various governments donated, all sorts of institutions were throwing all types of PPE on boats and whatnot and getting it over there, and there's been a tremendous amount. All the way back, I think there was in August, ships worth of PPE, because the person who arranged that was the opposition leader and not the government, not the president of the government. And so there's the distribution model that exists in these technically failed states are horrendous. And so we're left with a plea: we need healthcare workers. And Johns Hopkins, CPAR, has a GO team who has been trained to go into disasters, including austere conditions. And we're left with a gut-wrenching decision. Would we really send our team into a dangerous situation where PPE can't be assured, where 1 week you have one type of PPE, the next week you have another type of PPE, where only now is the intensive training starting to ramp up? What are their security arrangements? Can we get you out if you're there? There's a huge number of logistics, and yet everybody's looking for healthcare workers. And right now you're signing up to some extent. If you can go with Médecins Sans Frontières, MSF, you might have a fighting chance, but there's all sorts of other NGOs and groups that are looking for healthcare workers. And it's really not quite as simple as it seems on the surface.
Let me go to the next question.
Hi, thank you. My name is Jessica Atwell. I'm a PhD student here in global disease epidemiology and control. I think this recent discussion ties right into my question about the intended role that the Department of Defense is going to play in all of this. And we talked earlier today about the financial pledges, but if I heard correctly, I believe it was said that no military medical personnel will be involved in direct contact with patients. And I think we can all understand the complexity of that, but I would love to hear the panel's thoughts on that decision in light of, we keep talking about this severe shortage in trained healthcare workers and why the DoD is saying that its people won't be involved in helping with that.
Dr. Osterholm, did you want to take that?
Well, first of all, let me just say, I think that one of the historic natures of this outbreak is the fact that, MSF has now urged the military involvement, which after all those years of basically a detached position for all the right reasons. gives you an idea of just how far we've come in terms of just what the situation on the ground is. You know, we need, and I think this is what Gabe was getting at very clearly, is we need logistical support right now. Supply chains are broken. We also need command and control. You know, and I wrote that New York Times piece. I caught a lot of flack because I kept saying the UN had to take a leadership role here. Everybody said, well, the UN's broken, they can't fix it up. And I agree with that, but we needed at least a mission so that we could have a command and control structure where the U.S., the Japanese, the Chinese, the Cubans, the Russians, the Ugandans, the Canadians, the EU, and the home countries could all at least have one, hopefully, kind of command and control structure. That still is not fully materialized. It's still a problem. But I think the key thing that the DoD can bring right now is logistical support. If they can bring the personnel at the beds that can staff them, that's great. That is a very, very key issue that we're going to have. And the other thing we have to understand is so often we get into public health crises like this, they tend to be what I guess I would call short-term. Now, short-term doesn't mean a week or two, they're months. This one could go on a long, long time. And so we're going to have to also realize we're not in a sprint, we're in a marathon. And how we staff these are going to have to be looked at. How are we going to get, you know, you can get one recruitment over there, maybe two recruitments over there, but how do you get people to stay, and how do you support them emotionally, psychologically? And I don't think we've even thought that far down the road yet. We really need a much greater global commitment to respond here. You know, and again, I just want to echo the fact that I said earlier, the U.S., I'm very proud that the U.S. has done as much as they have, both from the government standpoint and from the private sector philanthropic standpoint. Where is the rest of the world? I mean, why are we not seeing that? And to President Obama's credit, he's been saying that over and over again the last 3 weeks. Where's the rest of the world? Secretary Kerry said it in his op-ed piece last week. Where is the rest of the world? That's what I find just, you know, if you don't care about the humanitarian side, shame on you. But by God, this is in your self-interest. You know, you've got to worry about terrorism. You've got to worry about the collapsed infrastructure. Why are you not there? That I can't understand.
I'd like to just, I'll turn to you in 1 second, but I would just, to pick up on that, I think it would be maybe worthwhile. I see Professor Peters and Professor Machado are still here, so they get to, they're eligible to be answering questions. And I think that the question and your answer raises the issue of the global leadership for the crisis in West Africa. Is it a lot of different things all kind of trying to move in the same direction, or, you know, the WHO in its role, and how does this test our system of international health, and are there other important points to be made there? But before I get the answer, I know you have something to say.
Well, no, I think if you want to keep going with that, I had a completely different strain of conversation.
Okay, I'll come back to you then. I just wanted to see, particularly from the broader international health perspective, international relations, this is a huge challenge to the global healthcare system, and is it up, you know, for the challenge right now? Feel free to come up if you want to speak to that.
Sure, you've raised a question that can't be answered in 10 seconds, but I will say that, you know, by all evidence, that coordination that needs to be there, that is, governments are pleading for and the people in the communities are pleading for, really hasn't been there. One of the unprecedented things that has occurred is that the UN has created a mission for the Ebola response, UNMIR. And this is the first time that this has been done for a public health event, another first among many. And that is meant to serve as the structure which brings all of these different players together and working towards the same goal. That's not to say that that structure is completely set yet. It really is not. But that's what is meant to happen. So the UN is meant to serve that role. That's the leadership function that they're meant to play. The U.S. military doesn't want to and doesn't need to play that role. They can't charge in there and take control. In fact, they are in support of the USAID mission even within the U.S. government structure. But they do provide this critical logistical and other support that was mentioned by Dr. Osterholm. So I'll just leave it there, but I think that there is a lot more to do in terms of generating the coordination necessary to get the resources where they need to be, when they need to be there.
Sure.
So
I would agree with that. I think we are in the process of basically rebuilding the coordination approaches as the epidemic is ongoing, and I think, in the aftermath, we're certainly going to need to relook at how this is done. I think that, the coordination center is being set up, actually physically going to be placed in Accra, or is there now, and in terms of command and control, but we're a long way from, a coherent approach, and I think when the time comes, we're going to have to relook at how we do that on the civilian front. There is a lot of leadership that is emerging both within countries, and again, I think, the example of Kabanga from Congo is a good one, as well as the countries that are being attacked or undergoing the epidemic. But I think that there will be a role for looking at new ways in which we can have preparedness in response to these kind of epidemics that we're going to expect again in the coming years.
Dr. Ostrom, you want the last thought on this, and then I'll go to Dr.
I just want to add one little piece to this at the risk of being controversial. I am absolutely convinced that this outbreak is WHO's 9/11, and that I think that the future of WHO is in question in terms of what and how it will act in the future. And I think there's going to be a lot of consideration about, is the current WHO outdated for its time, both in terms of its ability to respond, its authority, its financial support, its coordination, all of these things. Everybody thought when the international health regulations came through, this now set us into the future, and this was an organization. I'm not saying that it's going to be gone, but I don't believe that 3 or 4 years from now, the same WHO that we see today will be there 3 to 4 years from now. I think this will be a really very, very important time for reconsidering global health and how we respond to global health crises.
Professor Gladys.
Amidst all the discussion about global leadership and the importance of getting in supplies and infrastructure, I just wanted to briefly comment on the kind of issues David Peters was talking about earlier in the day, and the importance of local leadership and local mobilization, and the experience, just one hopeful sign, the experience of Lofa County in Liberia, where the cases there peaked, if I remember right, at about 790 cases in August, and have been going down ever since. And when people did a debrief last Friday in Monrovia about what worked and what didn't, they highlighted all those issues that were being discussed earlier today. Local leaders who were vocal and committed, mobilization through women's groups and youth groups and burial teams and monitoring teams to trace cases. There are some hopeful signs when we focus on local level interventions, local leadership, and social mobilization that can uncover those resources at the community level.
Great. Question?
My name is Bobby Borga Joe, and I'm from Liberia. Ebola is 12 of my family members are already dead because of Ebola. So it's personal to me when you have a conference like this, without throwing any dispersal on this group, but I think people from the 3 countries could have been included in this group. So that we don't just hear European ideas about how to help the black man. There are people on the ground already. When the issue started, people from Cuba approached the government. They wanted to send in their doctors. They don't send troops, they send doctors. The United States refused for a long time. Just recently, they released that. So we got 500 Cubans on the ground right now who are helping people in the villages. So we've been with America since 1822. You talk about the infrastructure. We gave you the first airline to fight World War II, Roberts International Airport. The relationship has not been beneficial in a real term. You want to sit around and talk about, how much vaccine you would produce, and that's good. But what's about working with local herbalists who may know something about it? That's all I want to say.
Good. Thank you. Question?
Yeah, I'm Miriam Henkens from Médecins Sans Frontières. First, I'd like to thank all the speakers because they give very clear image of the situation, on the science behind it, and all that is needed.
Sure. Could you be sure to speak in the microphone? Thank you.
I try. So MSF has currently 3,000 people working in the three main countries, 90% of them being national staff. We have 690 beds. We have admitted close to 4,000 patients, and so far with the data I just looked at that I received on Friday, 40% of them only recovered. So that means there is not enough done. There is not enough bed, there is not enough staff, there is not enough of everything. There is not a good model of care. We know that the treatment centers, we have them, are not sufficient. So there is a need to develop new models of care. Those models of care cannot be developed at all costs. They have to take into account a human way of treating patients, a human way of protecting the staff taking care of the patient, the staff taking care of the burial. Those standards are not developed yet. So we need to develop that as well. We need more people. Those people need to be trained, but that's not enough. Supervision is mandatory and should be continuous. Supply is mandatory, should be continuous. We cannot have staff without protection gear. So for the time being, to respond to the current outbreak, we really need more people involved. It's not that much a question of money for once. It's a question of people, it's a question of commitment, it's a question of using the science to improve what we are doing now. That's for the short term. For later, and as soon as possible, we need new diagnostics. Those diagnostics should help in triaging patients. We need new treatment. We need new vaccines. That's really necessary because this outbreak is there to stay. So we really need all that in the future. We need, therefore, imaginative way of doing the clinical trial. We need, therefore, ethical ways of doing those clinical trials that is understandable for everybody, not just for the ERB members. So we need really much, much more. And I would like to thank you for organizing this meeting, but I'm asking for more, as usual in MSF. Thank you.
Thank you. But before you go, could I ask you a question? If people are watching on the webcast or following on Twitter at Johns Hopkins SPH, and they want to know how they can help MSF's efforts specifically, they can go to your website and contribute money, I'm sure. But what else could people in the public health world be doing?
I think what needs to be done is people committing to participate to intervention with MSF or with many other organizations, but also people pushing the politician to make things move. There has been a lot of promises. We don't see that much yet on the ground. So I think that's a role of everybody, pushing the politician to get things moving. And for the School of Public Health, helping with the science to evaluate quickly models, realistic models of care, to evaluate quickly the new tools, to make them available and affordable. These new tools cannot be at minus 80 degrees. That's not going to reach the bush in Africa. Right. These new tools cannot be at high price when they have been developed with public monies and philanthropic money. The access issue and the affordability issue have to be taken into account as well.
Thank you. Comments, Dr. Glass?
I just wanted to plug very briefly something that I think people who are listening can do that will help the entire response. This is a shameless plug. Last Wednesday, we launched a website called EbolaCommunicationnetwork.org, and the purpose of this portal, which we checked last night, it has over 4,000 hits, and there are about 170 materials on it. The whole purpose of this site is for people to share experiences, materials, and media that they've been using. So I just wanted to quickly, since people are listening on the web, looking for very concrete things they can do, sharing your experiences in media and materials is now quite easy if you can go to that site. So thanks for the chance to shamelessly plug.
Great. I also have a sneaking suspicion that @Mike Clegg is tweeting right now. So, okay. Let's see, over here.
Hi, my name's Ted Schenkelberg. I'm a Bloomberg alum with the Human Vaccines Project. Question on vaccines and virus time versus bureaucratic program time. What is the pathway to licensure for an Ebola vaccine, and how are regulatory agencies responding to kind of the overwhelming risk given the traditional pathways?
Sure. Let me maybe do a little bit of an answer to that. As people may know, before I was the Secretary of Health in Maryland, I worked at the Food and Drug Administration. Food and Drug Administration would be the agency responsible for licensing. And there are some very good and creative people who work there on vaccines. They're going to be working very closely with the people developing the vaccines to think about the right kind of trials that would be necessary to establish efficacy and safety. They may be able to, and I mean, a lot of access could happen during the trials based on the evidence along the way. I think that it may well be the case, and other people here would know this better, that when you have different types of public health challenges, it may be you're going to need to get all the best people who understand the oversight of vaccines in a room to figure out how to set up the standards for those studies so that they can be done quickly and with creative designs like Professor Cass said, so that the answer can be known as quickly as possible. I think this is a challenge in a way to the regulatory system, but I can say I think knowing the people there and their commitment to public health, I think it's one that the FDA will be able to meet. But I'm open to other comments on that too. Okay, why don't we go? Oh, sorry.
I mentioned it very briefly, but I'll say it again. NIH is about to launch a comparison, actually, of 3 vaccines. The chimp adeno, the VSV, and hepatitis as the third arm in what is being rolled out as a phase 2/3 clinical trial. It'll be significantly powered, 30,000 people. And one would hope that, I'm not going to speak for the FDA, but one would hope that once the results of that study are analyzed, it would facilitate licensure of at least one of them.
Great. And let me tell a quick story about H1N1 and the vaccine at that time. There was a push at that time to consider sort of green-lighting an experimental vaccine and giving everyone an experimental vaccine versus pushing to get the data that could actually qualify for licensure. And the agency felt very strongly that it would be a lot better if it could be licensed and you wouldn't be going out having to get informed consent from everybody and you'd really feel like it was licensed. So I think that the framework of licensure and the fact that the FDA would stand behind a product that the benefits exceed the risks is very important, rather than just saying this might work, the risk is on you, whether it will or whether the balance makes sense. And so I think the idea is to have a study phase, to design it with NIH, and then hopefully the agency can be comfortable enough so that when you're actually rolling something out, we're standing behind a product that could make all the difference for people in West Africa. Yes, Dr. Cummings.
So one follow-on to this, a problem that would be great to have is how do you use a vaccine that actually has evidence of efficacy when you have 15,000 doses? And I think it's something that we need to start thinking about and engaging country partners, because having 15,000, having 100,000 doses of vaccine, it's not all that easy to think about how you'd actually use those. Spatial targeting, obviously healthcare workers would be an interesting group to target as well, but there's going to be lots of issues of equity, of the perception of how it's being used, and actual sort of trying to figure out how it would be most effectively used to curtail the outbreak.
Great. Next question.
Margaret Kahn Himmelfarb. I'm an alum of Bloomberg. Not on?
Sure,
Not
and
higher, lower?
we may be winding down. This may be the last question if we're sticking to one.
I'm an
We'll see.
alum of Bloomberg School, and I have 2 questions. The first is, as we have trauma centers in various communities, is there any wisdom in designating specific healthcare facilities as first institutions, at least until the point that, God forbid, they might be overwhelmed, to respond to people who have suspected cases of Ebola?
So you're speaking to the U.S.?
Yes, and other more developed nations, yes.
Sure. Dr. Kellen, that seems right up your alley.
So as you know, initially, the recommendation was to shelter in place and any hospital in the U.S. was felt that they should come up to par and be able to take care of patients. People had already been questioning that regardless, and Dallas, I think, changed the whole specter, but let me give you some insight as to what that really means. a real biocontainment unit is a concept that is completely sealed off of all other patient areas and is standalone. We have 4,200 acute care hospitals in the U.S. Half of them are under 100 beds, 180 some odd VA hospitals, something like that. And we are likely to go in that direction. We made a recommendation last night, in fact, at a meeting, that we should have a designated site from one of our hospitals. And I won't get too into that because we haven't finalized exactly where. But even in the short-term building that has to occur to meet certain specifications is enormous. And right now there's Nebraska and the NIH and Emory that had preemptively done this like over a year ago at a very high cost. And we talk about having a public health system, but we have a public health system with a boatload of private hospitals who are now faced with, I want to play, I want to contribute, I want to be a designated site because we think that's our responsibility. Now I got to figure out how to do it quickly and pay for it. And, oh, by the way, when I'm a designated site, what about all my other patients? Suddenly, where are they going to go? Do they want to go to the Ebola hospital? Remember, we face these same issues with HIV. I think we can overcome them. And we as an institution decided back in the early 80s to be a major HIV treatment center, research center, and so forth. And you know, today we see the benefits of that. But back then, everyone had the same scare. Oh my God, if we're the designated HIV hospital, all the patients will run away, and what happens to our business model? Where's the public health system that might shore that up? So it's a very complicated thing, but I think we're going to be going in that direction apart from us. The concept of designated centers is probably the right way to go with a highly trained group of people who take care of these patients.
Thank you. Dr. Rothman, anything you want to add to that? No. Okay. Question?
Yeah, I think, hello? Hi, my name is Kevin Burns. I'm a family medicine doctor.
Sure, could you speak in? And let me just say we've been given a little extension, so we're going to go for a couple more questions. Go ahead.
Is this on now?
So we could turn that mic on if we can.
This way? This way?
There you go.
Okay. Hi, my name is Kevin Burns. I'm a family medicine doctor, and I'm currently a general preventive medicine resident here at the School of Public Health. On September 13th, Dr. Olivet Buck became the fourth Sierra Leonean doctor to pass away from Ebola. And it occurred when, under a situation where there was a hospital in Germany ready to receive her, and the WHO declined to fund her transportation. And she's just one of a number of key, I would say almost irreplaceable assets in this epidemic of local doctors who are on the front lines. And I wonder if the panelists are in support of considering transporting local doctors to outside facilities, particularly given that we're transporting a lot of foreign aid workers out of the area when they become sick.
Great question. Nancy.
It's a great question, and I want to say a couple things about it. I want to separate the question about whether there's a duty to take them out from whether that's WHO's responsibility. First of all, the fact that at least so far, employers have made commitments to their own employees, international employees, to airlift them out if they get sick, is not something that is unusual. And I would argue is something that is essential. I mean, it's part of what Gabe was talking about. If Johns Hopkins is going to send people over, my goodness, Johns Hopkins has to guarantee that they're going to be well-trained, that they have enough equipment, and that if something happens, they're going to be airlifted out. In the same way I've said analogously that if somebody from the Washington Post or ABC News was covering Ebola or the war in Afghanistan and their leg gets blown up, you assume that ABC News is going to airlift them out. So the fact that that has been happening so far with the international people is part of the history that international employers have. It then gets complicated when we see what happens to people in Sierra Leone. It seems to me that I'm really making this up, But to be clear with the transparency, there are groups right now that are willing to contribute an extraordinary amount of money to Ebola. There are some very wealthy foundations trying to figure out what they can do that would be helpful. And I think a lot of us would have a lot of ideas of some things that they could do, particularly in the context of not being interested in going, but being willing to donate a lot of money. It seems to me that that is the kind of thing that could be potentially set up. I think that the WHO is very, this gets too much into what is the role of WHO. I don't know that that's the role of WHO, and there would be a very complicated, slippery slope that would really have to be anticipated of the number of healthcare workers who are getting infected and what the budget would be. It's not really just one person who would be airlifted to Germany. It would be a lot of people. And that's an important thing to take on. But I think it's a really important conversation to raise, and I think it's something to think about addressing. But I want to separate that from the role of WHO.
Dr. Rossman.
Thank you. I just want to follow up on Nancy's very thoughtful comments. I agree 100% with her, but let me just give you some context to this. At that time, the airframe movement in and out of the area was dramatically impacted by refusal for landing rights. And there was actually a problem occurring at the time of just trying to even get certain aircraft in, plus the U.S. contract through the USG for who could come in and out. We even had a problem here in terms of the only aircraft that was available was one where they could put you in a pneumatic tube basically for 12 hours and seal you off from everybody, and that was the only contract that existed. In addition, up on the Hill, in fact, one of the very first briefings I did up there, a very senior congressman was just really angry we brought this individual back to Atlanta for treatment. Said we were just contaminating our own shores, what if the plane blows up over Atlanta, et cetera, et cetera. And it was interesting because I realized I had a real hot live wire on with that one, okay, because it was the first question in the brief, and I thought if I screw this one up, I'm done. I mean, I might as well just walk home right now. And I actually painted out the picture for him of saying, you have to understand, first of all, think of this as a serviceman issue. And if we send somebody into harm's way, are we as a country willing to bring them back if they give their life to this and they want to die back here? And I said the biggest problem we have right now is getting people to go there, because it's not just that they're afraid, but if they get sick, they want to know that somebody's going to bring them home. And it was amazing. He turned 180 and said, I never thought about it like that, and he's now become one of the strongest supporters of bringing people in and out. I think we have some education to do here in terms of our policymakers, our funders, and I think, as you said, I think people would be willing, why that is important. It's not two classes of care. It's really about a standard that says we will bring our own home, whoever they may be, meaning not just the U.S., but any country, and that's one of the few fringe benefits you might get from giving a precious part of your life to do this, and we should make that a hallmark of anything we do. We will bring you home. I think that's huge.
Sure. Lenny Bernstein.
One thing I've been a little bit surprised about, to move this beyond healthcare workers just to the general population, is if you talk to people over there, they know that healthcare is more available outside of Liberia. And, because the only check is the infrared thermometer, you could take a few Tylenol if you thought you had Ebola or you were coming down with Ebola and get on a plane and very easily clear the fever check. So really the thing that's holding most people back is the money for the plane flight. Most of them don't have it. I'm not talking about healthcare workers anymore, but that will raise, if that ever were to happen, if people were to say, I'm going to try to find care in Brussels or Ivory Coast or Mali or something, that's going to be a whole another situation.
I think maybe...
John, I think Trish had a comment.
Oh, sure. Didn't see it.
So I am not at all an expert in the ethics of this, but I would go back a little bit to what I said, is that there are very relatively simple things that we can bring into the field to really improve our medical response in the field. And so while we can talk about bringing people out, I also think it's really important that we change the discussion about how much we should be offering people in the field. And You know, even with very simple interventions, we potentially can improve the outcome of the myriads of healthcare workers that are there. And so when I think about it from a public health point of view, I really feel that this has to be part of our messaging, is that we need to change the paradigm. We need to really think about how we can decrease mortality there, because we may not ever have the funds to bring everybody out of Africa.
Before you go,
Yes.
can you maybe just follow up on that with, you know, what would you like to see available to everybody?
So the data are strongest with IV hydration, and this is even in the settings, and some of this work was done with Doctors Without Borders and other people, but just, you know, you're giving people 3, 4, 5, 6 liters. I mean, these people have a cholera-like diarrhea, and so you have to aggressively hydrate them with electrolyte replacement. And this has even been done in the setting of not really having these portable point-of-care testing machines that allow us to look at electrolytes and even do this rationally, or, you know, how we would do it in a more developed setting. So, you know, that would be something. You can manage their nausea. You can manage their fever. So there are things that we are doing in developed countries that aren't really necessarily that expensive, that can be part of this bundle of care. And then, you know, the other thing is just to sort of think also on the palliative end. We can improve the palliation of the people who are dying, and how can we incorporate some of that into a bundle of care. So that's part of it. There are data out there suggesting that empiric antibiotics, something very simple because there's translocation of the GI flora, may be an important component of this during the illness. And, you know, again, it's not terribly expensive. And then the other huge sort of debate discussion going on is, when you're in this part of the world and a patient comes in who's febrile, should we empirically be treating people for malaria while we're waiting for the diagnostic test? So we aren't talking about fancy stuff. We're not talking about x-ray machines or whatever. We're really talking about basically treating this as, you know, a diarrheal illness, and maintaining basic hydration with electrolyte replacement.
I think we'll go with one more question.
Hi, Catherine Bertram again. This question is for Dr. Osterholm. It's about what you had said earlier in your remarks, which I thought was a big deal, around cases where people are not presenting with fever. Something that I had actually heard when I was in Sierra Leone back in July, not for any reasons for Ebola, but for a malaria project. And I thought the comment was odd, and I've heard it, you know, a couple of times since then, last time from you. And so if you look at the literature from the CDC, from the WHO, from other organizations, you don't see that coming out. You see, you know, fever and all these other symptoms. You must have fever, et cetera, et cetera. So can you shed some light on this and help me understand what's going on?
Thank you for that question. I can't shed light on it other than to say I think it's something we have to understand better, and we can't be afraid to ask the question. The problem is it's a question right now that's tied so closely to a policy that is so rigid that people, I mean, I've actually heard EMS people get into a debate with 1015 or 101, I mean, which we all know is really so immaterial to the whole issue. Again, I think we just have to keep an open mind. Do I think most patients, as we've seen it in this outbreak, present with fever? Absolutely. Do I think that there may be a subsection or a subgroup that we don't know about that we need to understand better? Yes. What the implications of that for screening? Well, they're real. And what I worry about is we're ready for another black swan event. If one patient presents at a U.S. hospital, it'll have to happen, and doesn't have a fever, ends up having Ebola, an emergency room gets exposed, and everybody will come back and say, see, public health didn't tell us the truth. You didn't have a fever. We should prepare for that now. And then we need to study this. So I don't have an answer, I don't understand it, but I have gotten too many, just as that article, I was not part of that LA Times article, but I can tell you that I've gotten the same feedback from various groups of physicians who are reporting the same phenomena of a real significant subset of the patients are not presenting with fever right up through death.
I would just say from the State Health Department perspective, we have a pretty low threshold for people to call us, and they have been calling us from around the state with all sorts of cases, questions, and we want to be open to whatever could happen, and we'll be working with facilities without too many preconceptions so that we can be prepared for anything that could come to Maryland as best we can. I want to thank the panelists for some terrific insight. I want to thank Professor Pecos for organizing this terrific program on such short notice, and the School of Public Health for really showing all of the different incredible resources that can be brought to bear to talk about something that is really an incredible test right now. It's a test, I think we've heard, for the international health system. It's a test for our ability to scale up support to areas of the world that are in dire need. It's a test for research, not just to understand this illness as well as we can, but a test for our ability to develop therapeutics and diagnostics and ethically and quickly test them. And it's a test for us to be able to implement community projects and communicate about them in a way that are effective at the local level. And finally, I would say it's an incredible test of our ability in the United States as in West Africa to support frontline healthcare workers. Because if we can't do that, I don't think we have any chance of being successful. And we're in the middle of this test. I think we've certainly heard that there are a lot of reasons for concern right now, but it is certainly a test that the world cannot afford to fail. And I think we've all learned a tremendous amount from this panel and from the rest of the day. And for the concluding comments on it, I would like to ask Dean Clack to come up.
Thanks, Josh. Well, Josh, I can only imagine how busy you are, because I know how busy I am, and I know you're busier. And so to take time to come from your duties as a state health officer here, we really appreciate it. And the panel discussion and the whole day was in many ways an incredible day. And so my notes here say, summarize the salient points of the day's discussion. So, which is, we only have, I only have 2 minutes, so we have to stay another day to do that. But I would point people to the Twitter feeds from the school and from various others, from you and from me and others that have been summarizing, and many of the participants. And at our school's website, Ebola Forum, we will archive the presentations. They'll be available on video, and the PowerPoint slides will be there as well. I think, I heard so many insightful comments today. Maybe the best metaphor was Mike Osterholm, who has many great metaphors, was that if you give a great neurosurgeon a hammer and a chisel, they're not going to do a good job. And we've given public health workers, frontline workers in Africa, a hammer and a chisel. The most poignant was the man from Liberia who got up and told us that he's lost 12 family members and that Cuba is there, we're not, and pointed out that there's nobody from West Africa on the podium. And I apologize for that. We thought about that. We went down, we tried to get some people, and it just didn't work out. But when we sent out the agenda yesterday, Lisa Cooper, who's in the School of Medicine, also pointed that out to me. And we tried, but we failed, and we apologize for that. I think that to think that this happened in basically 6 days was just incredible. And I take some solace from what Josh said. He called this a test. That's a great statement. This is a test. But I think, and Mike said that WHO is going to change. There's no doubt about that. But we're all going to change. I mean, this is, when you think about that we now have vaccines which have been sitting on the shelf about to go into clinical trials in such an incredibly short time, it shows that we are moving. Maybe we're not in virus time yet, but we're not where we were 2 or 3 years ago. And we saw that with SARS, how SARS changed things and in many ways made our system better. And my hope is that this current test is going to make all of us better at what we do. I want to thank Andy Pecos, who also has a day job, who's worked nonstop in getting this together. So thank you, Andy. And then our Office of External Affairs just did an incredible job. And I was watching the live feed. We had somewhere around 2,500 people watching us live, and the sound quality and the video were excellent. And that's important, I think, to get this information out. The interest that people showed about today shows how hungry we are for information and for insights. And we couldn't have had better insights than from our speakers. I want to, many of our speakers were in-house, but there were several who traveled. You know, Peter Jarling, it was a tour de force. That's what I tweeted about your talk. It was a tour de force review of vaccines and drugs. Mike came all the way from Minnesota. You know, and then of course Josh came from several blocks but a world away. And Lenny came back from Liberia and is here with us, and brought insights that were really remarkable. I did want to mention that our magazine, which I don't have a copy of, but there's probably one over there, and we'll have some outside, has an article on some of the work that's going on behalf of the school on Ebola. So take a look at it. It's also on our website. Yeah, Andy, just pass it up. So it's out there. We have it all around the school. So please pick up a copy. And in fact, we're having a live event this afternoon from 3:30 to 5. If you're still in the building, a live kickoff for the magazine. We'll have some refreshments, and we'll talk about the articles in there, including the Ebola one. So I hope to see you there. But again, my thanks to everybody who did such a phenomenal job, and I think we'll look back on this day as a day when our school rededicated itself to addressing this topic of Ebola and to emerging diseases and support of frontline health workers around the world. So thanks very much.